Recording in progress.
To begin, let us acknowledge that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. We thank the Indigenous peoples of this area for the care of this land for thousands of years, and we hope to honor and respect them as we hold our virtual event today. I'd also like to take a moment to thank everyone for joining our event today. Our speaker this afternoon is Dr. John Aucott, who will be presenting on Lyme disease and infection-associated chronic illnesses. Dr. Aucott is an associate professor of medicine at Johns Hopkins University Medical School and the director of the Johns Hopkins Lyme Disease Research Center. He is the principal investigator for the SLICE studies of acute Lyme disease and post-treatment Lyme disease. His research interests center on the pathophysiology, diagnosis, and treatment of persistent illness after initial antibiotic treatment of Lyme disease and have resulted in over 40 peer-reviewed publications. He is also program director for the Johns Hopkins Fellowship in Lyme and Tick-borne diseases. Dr. Aucott is an internationally recognized expert on Lyme disease and has served on groups sponsored by the Institute of Medicine, the Canadian Institutes of Health Research, and the U.S. Department of Health and Human Services. He is also the past chair of the U.S. Department of Health and Human Services Tick-borne Disease Working Group. We will have Dr. Aucott present, and then we will open for questions from the audience. You can ask questions by entering them into the chat box, or you can raise your hand using the icon or unmute if an opportunity arises. Please help us welcome Dr. Aucott to the podium.
Great to be here. Thanks very much. You should be seeing my screen now.
You can see it, yes.
Good. All right. Well, it's great to be here and to speak today on what my passion is, which is Lyme disease and post-treatment Lyme disease. I'm actually in the division of rheumatology, but I'm a board-certified infectious disease physician. And these are my disclosures. I don't think any of them affect the presentation today. So infection-associated diseases are not new. In fact, some of the classic ones you're aware of, like rheumatic heart disease after group A strep infection and Guillain-Barré after Campylobacter and others have been around for quite a long time. So there is this link between infections and downstream illnesses that may not look anything like the original infection. And some of these infection-triggered illnesses look very similar and are called syndromes because they tend to have a constellation of symptoms that are similar. So after post-Ebola syndrome and after SARS-CoV-1, we saw outbreaks of infection-triggered fatigue. Of course, ME/CFS can be triggered by Epstein-Barr virus infection, again, fatigue, fibromyalgia, post-treatment Lyme disease, which I'll be talking about today, and then also comparing to long-haul COVID or post-acute COVID, again, a viral, in this case, infection-triggered syndrome, and these all kind of look the same, right? Fatigue, cognitive symptoms, and musculoskeletal pain. So we'll start with and focus mostly on Lyme disease today. So this is a schematic of how Lyme disease progresses. And we're focusing first on the natural history of untreated Lyme disease. So the tick bite 10 days later, approximately a round red rash, usually not a bullseye, actually usually just round and red, followed without treatment by neurologic, and this is where carditis is as well. Timeline on the bottom here, so this is like 6 to 8 weeks. And then if untreated, in the mean of 6 months later, late Lyme arthritis, which was how the disease was discovered in Lyme, Connecticut by Alan Steer. These manifestations here on the top are all active infection manifestations. So all of these manifestations are what happened with active infection. If you do an arthrocentesis of this knee, and do a PCR for Borrelia burgdorferi, it'll likely be positive because these are the natural outcomes of untreated active infection. But what we're going to be talking mostly about today is not untreated active infection. We're going to be talking about the sequelae after treatment. And the one that's the best described is actually post-infectious Lyme arthritis. It used to be called antibiotic refractory Lyme arthritis. These are the people that have active swelling and synovitis on exam after treatment. It's post-infectious. These people have had 2 to 3 courses of antibiotics, and yet they still have objective manifestations of arthritis and synovitis. And this was the first example that Lyme disease, an infectious disease, can also result in an ongoing inflammatory process that's not thought and has not ever been linked to ongoing active infection. This is thought to be an autoimmune arthritis at this point that's triggered by Lyme infection, but is no longer dependent on viable Borrelia burgdorferi in the joint. So this has been known long ago, but what's newer is the post-treatment sequelae that occur after earlier stages of Lyme disease and treatment. We call these post-treatment Lyme disease. And recently also now we're recognizing inflammatory outcomes after treatment of early stages that kind of look like rheumatoid arthritis or psoriatic or reactive arthritis. All of these phenomena, again, are after treatment and are not thought to be due or dependent on viable Borrelia bacteria in the tissue. So that's what we're going to be talking about today. And I may jump back and forth between names for what we're talking about, because over the decades, this illness has been called many things. And so most recently, people are calling it persistent Lyme disease. I prefer to call it persistent symptoms associated with Lyme disease, although I also like long haul Lyme disease because it kind of gets at the idea, similar to COVID, that these long haul persistent symptoms occur after the initial infection. But it doesn't matter what you call it. This is a phenomenon that's been recognized since the 1980s in Lyme disease. The comparison to COVID, I think, is good because it's really easy to understand in COVID that acute COVID is obviously a fulminant viral infection, and the people that get super sick, they have pneumonitis, abnormal CT scans, their lungs are acutely inflamed from active viral infection. And that's sort of like active Lyme disease. There's a phase where you're in active infection and the damage is being done by the infection or often by the host immune response to the infection. And then in COVID, what we saw is that active acute symptoms isn't the whole story though, right? There are also immune-related phenomenon after the infection. There's also damage that the acute COVID does, chronic organ damage that has a lifetime that may be forever, but certainly can be chronic, because if in severe COVID, if there's damage to the lung, that scarring and fibrosis may never resolve. But then the area that's closest to post-treatment Lyme disease is what's called long COVID. And these are not the acute symptoms of acute viral infection, but these persistent symptoms. And again, it has the same phenotype or syndrome. It's got fatigue, cognitive complaints. In this case of COVID, you know, the sense of smell often lingers. And this long COVID set of symptoms, except for the smell and taste, look almost identical to post-treatment Lyme disease. So what have we learned about long COVID? Well, it's not uncommon. The range is large because it depends on how the case series are put together, but it's somewhere in that 20 to 30% range, which is, you'll see later, is similar to what we see after Lyme disease. Really interestingly, COVID long haulers can occur in mild initial COVID or severe initial viral disease. And this is a really important observation, that it doesn't just occur with severe COVID, it also can occur after mild COVID. Women may be at higher risk. And a very important thing that I'm going to echo later on, it's not just the background level of these common symptoms in the population. You know, skeptics would say that long COVID or long Lyme is just the common fatigue and achiness and brain fog that everyone on this call has, you know, because we're tired from working on grants or being up all night. But it's not. I'll show you later, it's different. It's not just the background level of symptoms in the general population. And this study here showed that it's also different in COVID than it is after influenza. So in other words, these syndromes don't occur with equal propensity after all infections. They're more common after certain infections like COVID and Lyme disease than they are after infections like influenza or a urinary tract infection or a bacterial cellulitis, or something about certain organisms that seems to trigger these persistent symptoms after the acute phase of infection. And we'll show you that they're not trivial symptoms, they result in a loss of function. So when we look at Lyme disease, post-treatment Lyme disease, we've looked for a long time at the types of symptoms that we see. And in Lyme disease, fatigue, joint pain, focusing and concentrating. In our studies that I'll show you later, we compare the symptoms in our Lyme cohort to controls without exposure, who've never been exposed to Lyme disease. And you can see controls with no Lyme history have these same kind of symptoms, but they're mild or occasionally moderate. In other words, light colored, as opposed to in post-treatment Lyme disease, where they're often severe. So that's one of the other differences. The symptoms aren't just the hum of the background in the general population, because they're much more severe. And when the long COVID patients started reporting their symptoms, these were the original reports from a group of patients, actually. This was not from a study. These were self-reported symptoms. I call these butterfly graphs. The graph looked almost identical to what we see in Lyme disease: fatigue, aches, difficulty concentrating, focusing. The only thing that was different was the shortness of breath or breathing complaints were different in the long COVID. We don't tend to see that in the long Lyme patients, and that's probably obviously because long COVID patients started with a respiratory illness. So we don't see that, but otherwise they look pretty darn similar. Again, the phenotype of these infection-associated illnesses is very similar. These symptoms, for whatever reason, tend to travel together in these illnesses. And this is another way of looking at the symptoms in long COVID, and it splits them out by those that occur in the first 90 days versus the second 90 days. And you can see that, symptoms are common in the beginning and in the end of this 180-day period, but some are different how they split out, obviously. So the breathing problems tend to be prominent more early and less so later. Fatigue, the same. Anxiety and depression tend to be common across all of them. Cognitive symptoms, so there's a little difference in when the symptoms start and when they appear, but by and large, it's similar to what we see in long Lyme disease, except for the respiratory symptoms. This was another neat study that I thought really gave some insights into long COVID. This was a huge study out of the VA, and it split the patients into three groups. The green bars are the patients that were not hospitalized. The red were hospitalized but not in the ICU, and the purple were in the ICU. So each of these three groups, now we're looking at the adjusted hazard ratio for these different symptoms. And what you can see is really interesting. Stroke, which occurs in very seriously ill patients with COVID, especially ones that are in the ICU, you see that, the ratios are much higher in people that are super sick that are in the ICU, and is rare in people that are outpatients that are never hospitalized. So a symptom like stroke isn't a typical part of a long Lyme or a long COVID presentation. But memory problems, which are, you see that the hazard ratio in the outpatients isn't all that much different like it was in stroke compared to the hospitalized. It still is more common in hospitalized, but it's also pretty common in the outpatients. So again, the symptoms like memory problems, and headache, are much more common in outpatients as well, as opposed to big ticket items like stroke that or hypoxemia that you're really going to see more in people that are hospitalized. So are these important symptoms? This was a very recent publication looking at the outcomes in terms of function in long COVID patients. And you see that stratified by age group, that had a large impact on cognitive functions on work and on daily life. In other words, an important part of these syndromes is that they're not just the mild background symptoms of daily living. These symptoms result in dysfunction and health-related quality of life decrements as the individuals experience them. They impact their life, their daily life, and their work. And these are also hugely impactful in terms of the absolute numbers. These are cumulative in daily cases, surviving cases, of COVID. And, we're talking obviously in the millions. And this is in, the United States. But, if a certain percentage, let's say 20%, get post-acute COVID symptoms, these are big ticket numbers. These are tens of millions of people that are going to likely be suffering from these ongoing persistent symptoms. And we've done the same thing with Lyme disease. If the reported cases are in black, but the true cases are probably 10 times the reported cases because of underreporting in the United States. And if the incidence of post-treatment Lyme disease is 10%, then 10% of the green bar, but its prevalence because it's chronic, the numbers of people with post-treatment Lyme disease is in the hundreds of thousands in the United States. So these are big ticket items. These aren't small numbers of people that are likely suffering from post-treatment Lyme disease, or also this, we're gonna have millions of people suffering from long COVID. And we recognize this early on, and Allison Redmond, my colleague, and I wrote a letter to the Lancet saying, that's long haul COVID patients, we need to understand that, these look similar to what we've been studying in long Lyme, and that, that we want to warn people that, to avoid the pitfalls, from the past of dismissing these patient reported complaints, and that realize that the resolution of the objective findings of the acute illness isn't the whole story, that these persistent symptoms are impactful and significant. And now we're starting to realize how important they are after COVID, and we've known this a long time after Lyme disease. But they're tough to understand and they're tough to study. So, I've been studying long haul symptoms in Lyme disease for a long time, and they're really hard because they're hard to measure, right? The symptoms in long haul COVID and Lyme are subjective. They're patient reported symptoms. They're not objective. In other words, we're not talking about things that you can easily see or measure. These are symptoms, patient-reported symptoms like fatigue and cognitive symptoms. And they have a high prevalence in the general population, like fatigue, although in Lyme, post-Lyme, they're much more severe. They overlap with the vegetative symptoms of depression and anxiety. And that makes it difficult to understand because patients with long-haul COVID and post-treatment Lyme may develop a secondary anxiety or depression after their illness that adds to the symptoms and confounds the presentation. And diagnostic testing is especially difficult in these illnesses because we're in the convalescent phase, right? When you see somebody with long haul COVID or post-treatment Lyme, you're not seeing them at chapter 1 of their illness when they have acute symptoms. So if it's a long haul COVID patient, by the time you see them, their PCR is going to be negative, right? And so these patients are hard to diagnose on blood tests because you're really going to be relying on antibody tests, not on PCR or direct tests. So, if you have a patient with COVID, we're past the PCR stage, we're in the antibody stage. So to diagnose long haul COVID, you're going to be dependent on antibodies. But of course, there's going to be a lot of people in the general population that have those antibodies left over from their COVID who don't have long haul COVID. So antibodies don't tell you as much as you'd like to know. There's going to be a lot of false positive tests just because of the seroreactivity in the general population to COVID. There'll be false positives. It's the flip in Lyme disease, actually. In Lyme disease, the antibody tests are not all that sensitive in early infection, and they're also not all that sensitive in the convalescent phase after treatment. So in post-treatment Lyme disease, in other words, treated early Lyme disease, the convalescent antibody levels are actually insensitive. That may sound wrong to you because you may have heard that antibodies in later stages of Lyme disease work. Well, they do in Lyme arthritis, which is untreated Lyme disease that's persisted for months, or they're pretty good in neurologic Lyme disease, which is untreated Lyme disease that's persisted for months. But in post-treatment Lyme disease syndrome, they're often patients that they are by definition post-treatment. So their convalescent phase antibody levels and the IgG convalescent antibodies are not sensitive for post-treatment Lyme disease syndrome. And so because of that, the Infectious Disease Society case definition for post-treatment Lyme disease syndrome requires these common symptoms we talked about. They have to have a functional impact. They have to occur in the context of treated Lyme disease and treated co-infection. you can't have a different illness that causes the symptoms like hypothyroidism or something. But the interesting thing is serology is not part of the case definition of post-treatment Lyme disease syndrome, because again, serology is not sensitive in the convalescent phase of early treated Lyme disease. And I'll show you that later. So it's really, the diagnosis is based on evidence of a physician documented case of Lyme disease that preceded the onset of their chronic illness in somebody that was healthy before. So it's really a clinical diagnosis based on meticulous documentation of the pre-Lyme health and the post-Lyme health, and the fact that they had a Lyme disease diagnosis that was treated, but the patient never really got better. And that's really the case definition that we use for our research. Now I'm going to tell you a little bit about our research, because I think it's important research to really document post-treatment Lyme disease syndrome in a research setting. We call these the SLICE studies. These were the first prospective controlled studies of acute Lyme disease that were focused on long-term health outcomes. It's a 2-year prospective cohort study, including cases and controls. And we wanted to examine post-treatment Lyme disease syndrome. So we had meticulous exclusion and inclusion criteria. The exclusion criteria, we eliminate anyone with a look-alike illness that would confound the diagnosis of post-treatment Lyme disease syndrome. So basically all the enrollees had to be healthy before they got their Lyme disease. They couldn't have had a prior, fibromyalgia or major depression or other illness that would confound the diagnosis of post-treatment Lyme disease syndrome. And then we have meticulous inclusion criteria. For these studies, everyone is enrolled at the first stage of untreated Lyme disease with erythema migrans, as validated by photographs of all their rashes and microbial validation by PCR for Borrelia burgdorferi. So we really wanted to design the pristine study to answer the question, does post-treatment Lyme disease syndrome occur in people that are enrolled at the time of early Lyme disease, obviously treated, and then followed up over a 1 to 2 year period? And there's both patients with Lyme disease and then controls as well. And so this study, we've cut the data now and looked at the first about 270 enrollees and examined their outcomes over these follow-up visits. We chose 6 months as the endpoint because that's the case definition of post-treatment Lyme disease. Asks that the symptoms after treatment persist for at least 6 months. And so at 6 months, we look at their symptoms and their health-related quality of life, and we compare it to the controls. And there's 3 potential outcomes. One is that they return to health after their early diagnosis and treatment, and that's 57% of the patients. 30% have some symptoms at 6 months, but it has no impact on their health-related quality of life as measured by the SF-36, i.e. they have symptoms that aren't impactful, and we feel those may just be the symptoms that are overlapping with the healthy population that didn't have Lyme disease. In other words, the minor aches and pains of life is possibly this group, but the group we're interested in are the ones that have both symptoms and diminished health-related quality of life, and it was 14%, which is kind of in line with what we've estimated all along. We estimated it would be 10 to 20% from prior non-controlled studies. So you may be scratching your head now and say, well, yeah, but maybe that's no different than the general population. But remember, we had controls. So the rate of these symptoms and health-related quality of life impact in the controls that had never had Lyme disease and went through the exact same protocol was 4%. So if you want to subtract the 4% from 14%, you end up with 10%, which is again in line with what we had predicted, hypothesized, similar actually to a study Gary Wormser did at the same time, not using objective survey measurement of symptoms, but using other chart review, and he got 20% actually. So again, 10 to 20% is probably what it is in people treated for early Lyme disease. This is not a study of people treated at later stages of Lyme disease. And it's interesting to look at the symptoms in the Lyme participants versus controls. You can see again that both groups, participants with Lyme and controls, have similar symptoms, but the Lyme patients have much more severe symptoms. So if you only take the percentage of people with moderate to severe symptoms, you see fatigue, moderate severe fatigue is really only common in the people with Lyme disease. The controls without Lyme disease, the fatigue was always mild compared, so it's not moderate or severe. So the symptoms are similar in the cases of controls, but much more severe in the cases. So to summarize, 14% of the participants developed PTLD after treatment of early Lyme disease. This was 5.2 times as likely to meet the criteria as those without Lyme disease. It was slightly increased among females, and the patients also had higher odds of reporting moderately severe fatigue and muscle pain. They had worse scores on their SF-36 physical subsets and pain surveys. And we feel this is really the definitive study now that shows in a rigorously controlled study with controls that post-treatment Lyme disease syndrome is a real illness that occurs after treatment of early Lyme disease. So why does this happen? So I'm going to transition now to looking at why does this happen? What are the hypothetical reasons why this may happen? And there's really three major groups of hypotheses. One is that people with post-treatment Lyme disease syndrome still have persistent Borrelia antigens or infection in the tissue driving ongoing illness. The second is that it's more an immune phenomenon. As I mentioned, post-infectious Lyme arthritis is thought to be an autoimmune disease and maybe post-treatment Lyme disease. Symptoms are also immune driven, or it may have to do with altered neural networks, as in cytokine triggered sickness behaviors or glial cell activation, or you've heard of central sensitization and fibromyalgia. We'll talk a little bit about dysautonomia, or maybe it's a little bit of all three or different in different patients. So I'm going to dive into these a little bit. One very interesting study that just came out a couple months ago kind of begs this question about, whether the persistent antigens or infection and immune responses may or may not be linked. And it's related to this article that Bill Robinson at Stanford, one of our collaborators, published on Epstein-Barr virus. So again, another infection that's associated with persistent symptoms in chronic fatigue, but this was actually looking at Epstein-Barr virus and multiple sclerosis. And this study is a very beautiful, complex study looking at, the impact of Epstein-Barr virus, which many of you know, once you're infected with Epstein-Barr virus, your B cells are infected for the rest of your life. So it's a lifelong chronic viral infection. But what Bill's group showed is that this lifelong infection may trigger molecular mimicry and B cell transformation with CNS tropism, so that central nervous system autoimmune phenomenon, like are seen in multiple sclerosis, may be linked back to Epstein-Barr virus infection. So example of an infection triggering an autoimmune illness, in this case, a central nervous system autoimmune illness with myelin being the target of autoimmunity. So, it kind of begs the question of whether changes that infection can change immune responses or immune regulation, and that those downstream immune changes, even decades later, can cause illness. And so I just thought it was a provocative study about the relationship between infection and autoimmune diseases. When you go back to the mechanisms that have been proposed for long haul COVID compared to Lyme, which I just showed you, they're remarkably similar to the hypotheses for post-treatment Lyme disease. People have hypothesized subtle brain infection, autoimmunity, changes in blood flow, endothelial cell dysfunction and coagulation issues there, altered blood-brain barrier with the passage of serum inflammatory mediators, cytokines and interferons into the central nervous system, causing cytokine-induced fatigue, and then again, neural network alterations like central sensitization or autonomic nervous system dysfunction. You'll recognize all these hypotheses for long-haul COVID very similar to post-treatment Lyme and also similar to chronic fatigue syndrome. And it doesn't have to just be one thing. We're very of the camp that there's probably multiple subgroups in these heterogeneous illnesses, and it's not just one pathway. And is this person hypothesized for COVID? Maybe it'll be different things in different subgroups or combinations. In other words, in these heterogeneous illnesses, there's likely not just going to be one root etiology. It may be a combination of pathways, and it may be different in different patients. So what can we learn from the COVID, diving a little deeper there? I mean, COVID and long haul COVID has the advantage of having lots of pathology, at least way more than in post-treatment Lyme disease, where we never get pathology. And one of the initial observations is that, in brain autopsies of COVID-19, you actually don't see a lot of evidence for infection with SARS-CoV-2 in the patients. And so, as I'll show you in Lyme disease, demonstrating ongoing infection or viral infection, even with autopsy material, is not been proven out to be as productive as you would think. Now it's early and there's studies ongoing now, so this may change, but at least the initial studies didn't show a lot of active viral infection. It did show microglial activation, which we'll get to later. But when you looked for viruses in the brain, they were darn hard to find, and very rare viruses in this autopsy material in the central nervous system. And that's kind of similar to what's been found in the rare studies in humans and primate models of Lyme disease, trying to find Borrelia spirochetes in autopsy material or in animal models and in non-human primates is very, very difficult. If you find Borrelia in tissue, they're very rare and not a lot. And so, the idea of persistent infection as a mechanism for long haul Lyme has been very difficult to prove. And the evidence there is really limited to very rare case reports or animal models. But even there, it's not easy to do. But what is found, and this is from the non-human primate monkey model, Monica Ember's work, is that there is glial cell activation in the animal necropsy material. And so even though there may not be infection, there still could be evidence of inflammation. And it's a very interesting paper from Catherine Brissett's group about looking at a mouse model of central nervous system Borrelia. The mouse is never thought to be a good model for neuroborreliosis. So much of the work is done in non-human primates, but in her publication on a mouse model of Borrelia infection, it was very interesting that Borrelia doesn't make a good infection in the actual brain. The Borrelia tends to localize into the dura. And so maybe that's why we're not seeing Borrelia in the brain in humans and in animal models. Maybe in this mouse model points out maybe the Borrelia is really in the dura, and the impact on the brain in terms of inflammation is more from passive transfer of inflammatory cytokines across a leaky blood-brain barrier. And the brain is sick. There's microglial activation, but it's not from actually having Borrelia replicating in the brain substance, but more adjacent to the brain in the meninges and the dura. The other thing that's interesting to think about is maybe, it's the components of the Borrelia. This is a great article by Christine Jacobs-Wagner and Brandon Jutras looking at peptidoglycan. This is a component of the cell wall of Borrelia burgdorferi. And these very elegant studies looking at Lyme arthritis and post-infectious Lyme arthritis patients showed that the peptidoglycan actually can be found in the synovial fluid, even in patients that had had their Lyme arthritis extensively treated with antibiotics, that this peptidoglycan may be the trigger or the actual mechanism for inflammation in the joint, as opposed to viable Borrelia burgdorferi. So it's complex. The things driving the inflammation may also include components of Borrelia and not depend on viable Borrelia at the time of the inflammation. And then we're learning more and more about inflammatory and autoimmunity and COVID. And I think that story is only now being written, but inflammation and post-infectious infection triggered inflammation in COVID can be quite complex, and it can have one of many mechanisms, either through macrophages or B cells, dendritic cells. It's complex, and I think we'll learn more and more about how the mechanisms of autoimmunity and inflammation are triggered by these infections. And I thought a really cute illustration of that, you've probably heard of COVID toes. This is an example of how somebody kind of tracked this down, and in this case series showed that the COVID toes was due to a type 1 interferon response. So an example of how inflammatory mediators like interferons can cause a phenotype of inflammatory disease that is really the mechanism has to do with inflammatory mediators. And this, you could hypothesize a similar mechanism for why people get brain fog and cognitive symptoms from interferons impact on the glial cells and the CNS biology that they're impact. So now I'm going to transition a little bit to imaging, because that's a very favorite area that we look at Hopkins, and talk a little bit about imaging. So in the COVID field, there's some early studies coming out on FDG PET imaging of COVID patients, showing that the PET evidence of hypometabolism on PET imaging of brains, and these are in kind of subacute COVID patients. And that's not surprising because, that had been seen before in post-Lyme syndrome, but it's very good study, this initial study showing that hypometabolism is also correlated with cognitive scores. So a correlation between the brain fog cognitive scores and the hypometabolism on PET imaging. And in one of these cases where there was autopsy material, lo and behold, again, we see microglial activation in this one autopsy case in the white matter. So I'm trying to paint this picture of, CNS disruption on imaging related potentially to glial cell disease and inflammation, as opposed to overt infection and pathologic damage of the central nervous system. It may be more subtle than that and relate to white matter and gray matter glial cell dysfunction and inflammation. And the story is similar in Lyme disease. This is an old study by Brian Fallon's group that, similar to that COVID data I showed you, showed PET imaging, again, of hypometabolism. And these are patients with what was called at that time Lyme encephalopathy, or I would call today people with post-treatment Lyme disease and brain fog. But again, showing areas in the brain, predominantly in the frontal lobes, often of hypometabolism, just like we saw in those COVID patients. And we've extended those studies now at Hopkins. We have a DoD grant to study now functional MRI of the long haul Lyme, post-treatment Lyme patients, because taking Brian Fallon's work further, his metabolism studies, PET imaging was done in resting state. In fMRI, we're basically stressing the patients and asking them to do work while they're being imaged. So they're doing cognitive tasks while they're in the MRI scanner, and we're looking at functional MRI scans. And what you see in these images where the Lyme activations during the workload are compared to the controls, you see in red the areas of the brain that are activated in the Lyme patients that aren't activated in the controls during the task in the scanner. And you see that a lot of areas are activated in Lyme patients that really shouldn't be activated in these tasks. The tasks that the patients are doing shouldn't activate these areas. So what's really interesting is that the Lyme patients, they actually do okay on the tasks, but it takes them longer, and they have to use parts of their brain that the non-Lyme infected controls don't have to use. In other words, the Lyme patients have to work harder, and it takes them longer. They get the answers, but it's harder. And if you're a Lyme patient on this call, you probably resonate with that. The Lyme patients constantly tell us that everything's harder and it takes harder and longer to cognitively do tasks. And this is what our functional fMRI studies are showing us. And we hypothesize that that's due from glial inflammation. This is an old study we did doing PET imaging, not with glucose PET. This is PET using TSPO, which binds glial cells that are inflamed. And in these studies, increased uptake is related to glial cell inflammation. So in the Lyme PTLD patients, compared to healthy controls, you see a lot more glial cell activation as measured by this TSPO agent. And this was the first evidence that there may be glial cell inflammation that's underlying these problems that the patients are having, both in their functional MRI and also in their just metabolism with regular PET. So we think that's a potential unifying hypothesis about at least one aspect of the symptoms that you see in the post-treatment Lyme disease patients. Crossing over to why this may be relevant to other illnesses, ME/CSF, chronic fatigue syndrome, also has a lot of trouble with cognitive impairment. And in ME/CFS, the cognitive impairment is thought by a lot of authorities, including a colleague of mine, Peter Rowe, to possibly being due to orthostatic intolerance and poor perfusion. And there's a distinct subset in chronic fatigue, which he's also seen in POTS, in COVID, in post-COVID, where people have classic POTS. In other words, they have orthostatic intolerance. When they're standing, they have increased tachycardia, which is the hallmark of POTS. So when you go from supine to standing, you get this tachycardia, which defines POTS. And that's long been seen in ME/CFS, but is now also being seen in post-COVID. So that maybe this is one of the common mechanisms that underlies the symptoms of fatigue, at least, is this autonomic miscontrol of pulse responses with standing. And so the post-COVID clinic here at Hopkins has seen a lot of POTS, and it's hypothesized that the POTS has a link back to what I was showing you in the brain, right? That the POTS may link back to autonomic nervous system dysfunction. Because if you remember, your autonomic nervous system, the vagus nerve, controls a lot of this parasympathetic. The output of the vagus nerve controls the heart rate, blood pressure. And so if you have central nervous system inflammation in these post-treatment Lyme disease and other syndromes, dysfunction of the vagus nerve, which lives in the brainstem here, may cause the fibers going to the viscera and control them to have dysregulated autonomic functions, heart rate and blood pressure. And this may be the link to POTS and orthostatic intolerance in the relationship to fatigue. Interesting, the vagus nerve, I never learned this in medical school, but also sends signals backwards into the brain, and they go to the limbic system, amygdala, and areas that regulate emotions and behavior and memory, which is kind of interesting because part of the cognitive symptoms that post-Lyme patients have often can include behavior and memory problems as well. And there is this branch of the vagus nerve that goes backwards up into the brain. So if there's dysregulation or inflammation or dysfunction of the vagus nerve, there's a lot of potential impact. So you can treat, the reason orthostatic intolerance and POTS is important to recognize is it has specific treatment. And so for the clinicians out there, it's important to recognize POTS in your post-treatment Lyme patients, your chronic fatigue patients, and now your long-haul COVID patients. I'm going to end a little bit with some about treatment hypotheses. We're interested in again, microglial activation, and we're interested in the impact of drugs like tetracyclines, which are actually good anti-inflammatories and may act as anti-inflammatories, including for glial activation. We're interested in impacting vagal nerve dysfunction, and some people are looking at vagal nerve stimulation. We're interested in gut microbiome. We're also interested in mindfulness therapy as a way to kind of change the central nervous system impacts of these illnesses, and maybe to work on central sensitization. And so we're very interested in mindfulness. I just saw an article recently about something called forest atmosphere or forest bathing, a form of outdoor mindfulness that's practiced a lot in Japan. But we think a lot of different ways that are provoked ideas about how potentially to treat post-treatment Lyme disease syndrome. Johns Hopkins also has a big institute you may be aware of in exploring the psychedelics in the treatment of symptoms, and that have published a lot on the treatment of post-traumatic stress disorder, depression, and we're also interested in whether this may be an avenue to treat the central nervous system aspects of post-treatment Lyme disease syndrome using psilocybin and psychedelics, which are actually, there's a burgeoning research effort to look at these at places, especially at Hopkins. And so something, a novel way potentially to treat these illnesses. And then, of course, biologic anti-inflammatories, as we develop the biology of the inflammatory response. As you all know, there's multiple novel biologic anti-inflammatories that might be useful once we figure out the targets of the immune pathways that may be activated in these illnesses. So I'll end with research is knowledge and knowledge is hope, and that's what we're all about. This is our team at Hopkins. We're a classic translational research group where we see patients and study participants at an outpatient clinical center where they're enrolled in studies, and then their samples and the science is done down at Bayview Medical Center. Our imaging studies are done at the main Hopkins campus, and then we collaborate with the Applied Physics Lab, the School of Public Health, and really collaborators all around North America. And with that, I'll stop and take any questions.
Thank you so much, Dr. Aucott, for your engaging presentation. We're going to switch it over to the audience. I don't see any current questions in the chat box. So if anybody in the audience would like to raise their hand or unmute to ask Dr. Aucott a question, please go ahead. We have about 10 minutes for questions. Oh,
Hi,
Dr.
Dr.
Salmon, go ahead.
Just a quick question. What percentage of persons with Lyme disease do develop these inflammatory or post-Lyme syndrome? I probably missed in our presentation, but I just wanted to know.
So, our prospective study, the number was 14%. That's with treated early erythema migrans. The number is likely higher if you're treated at later stages like neurologic disease. There's not a ton of neurologic disease for us to study in North America, but studies done in Europe where there's more neurologic disease suggest that the rates may be higher, because the patients have longer standing unopposed infection before treatment. And so the rates may be higher, maybe in the 20 to 30% range. But in our studies, when you treat early Lyme disease, it's 14%. So most reviews say 10 to 20%. If you kind of count what's, the range of stages which the patient's treated.
Yeah, and a follow-up question, sorry, if you don't mind. If a patient come to the ER, get treatment for Lyme, we're thinking everything is good, and down the line, this patient develop these neurological findings. And now you're trying to elucidate whether these are really due to something else, because you would have gotten treatment for Lyme, so you're thinking, no, that's gone. So in the workup for such a thing, I mean, how often do you think that one would be thinking, maybe this is a post-event of a Lyme, versus this is now due to something new, totally new?
Yeah, so I'm an internist, so that's our bread and butter, right? It's like a patient that comes in with chest pain. Do they have esophageal dysfunction or cardiac disease or costochondritis? You got to do a general workup, because post-treatment Lyme disease is a diagnosis of exclusion, not, there's no diagnostic blood test. So it's a diagnosis of exclusion first and foremost. So You're right. You got to make sure they don't have a new, totally unrelated disease. I mean, in my general practice, the most common thing I see that confounds the diagnosis is sleep apnea is a common mimicker, right? If somebody has severe sleep apnea, it could look just like post-treatment Lyme disease, right? With fatigue and headache and all that. So you got to do a good general workup. But if that's negative and the person has a history of documented Lyme disease that triggered the symptoms and that you've excluded other things, that's the way you make the diagnosis. I think one thing that's not commonly done probably as well as we should is when we treat Lyme disease, we assume that we've treated the infection, so we're done with the patient. And a lot of times, I don't know where you are, but where I am, people don't sometimes rarely even schedule follow-up appointments after treatment of early Lyme disease because they assume that everyone will be better. But just because you treated the bacteria again doesn't mean that everyone will get better. So I think people should do follow-up appointments, a month or two later to make sure the patients really did get better. If they didn't get better, that doesn't mean they still have active Borrelia burgdorferi infection, but it may mean that they have post-treatment Lyme disease syndrome, and they may slowly get over that if you follow them for the next several months. And which is great, but the patients kind of need to know that you're following them and that you're can reassure them that they may likely get better. But some of the patients won't get better, frankly, and those people, are the ones that, if you exclude other things, they likely have post-treatment Lyme disease syndrome.
Thank you for the question, Dr. Salmon. We've got 2 now questions in the chat box that I will read off, and then we have an additional question from the audience. The first question is, could you expand on the microbiome signatures of Lyme disease patients?
Yeah, I don't know if I kept the slide on my, I did actually. So here's the microbiome signature. This is work from Kim Lewis. And he looked at our post-treatment Lyme disease patients. It's a different cohort than the one I was showing you, and compared it to healthy patients and also as a positive control ICU patients. And what was really interesting was this organism called Blaudia. There was an overabundance of Blaudia in the post-treatment Lyme disease cohort that wasn't seen in the ICU patients that had similar amounts of antibiotics. And so that Blaudia group really stood out, and Kim Lewis is expanding on that further with further work, but it may be actually a target for interventions, right? Because people with post-treatment Lyme disease syndrome have obviously gotten antibiotics because they were treated. So the treatment was antibiotics initially. And, there's this group of people that have Blaudia, and it's not a small percentage of them that have a Blaudia abundance compared to, the good bacteria, the Bacteroides. And that may be a target for future treatment with targeted, microbiome interventions. It's also, Kim Lewis is very interested in whether that's the rationale for developing antibiotics that have a narrower spectrum that wouldn't change the microbiome as much as Kim saw in these studies. So yeah, there is a microbiome phenomenon here that looks actually pretty significant.
Thank you. The next question from the chat box is, in addition to Johns Hopkins, which are global centers of excellence for research into long haul Lyme? And are there any notable favorites up here in Canada?
I can't answer that. I mean, so I will tell you that the Brian Fallon Center at Columbia has a large grant, and they just started a clinical trials network that we're part of at Hopkins. And so we're actually starting the first network in the United States that's focusing on clinical trials. And we're getting ready to try to launch some pilot studies for the treatment of post-treatment Lyme disease syndrome. So we're 2 translational clinical research groups in the United States. There's not many, to be honest with you, doing clinical translational research in Lyme and tick-borne diseases. We're actually doing human-based research is quite difficult for many reasons. And so there's not many, in the United States, you can count the number on one hand. And I don't know in Canada, to be honest with you.
Thank you. I'm going to go over to Natasha Bowser, who had her hand up, and then I'll come back to the additional questions in the chat box.
Hi there. Firstly, thank you so much for your really interesting presentation. I apologize if you've already commented on this. I had to step away for 10 minutes, but in your prospective study, or in any other literature for that matter, were there any children included, or do you have anything to comment on post-treatment Lyme in children?
Yes, that's a great question. You know, the word on the street is that kids are less likely to get post-treatment Lyme disease than adults. That's not been actually studied carefully, but that's the word on the street. There are no studies with children. Ours don't include children because of, you know, the IRBs are totally different so ours are 18 and older. There is an NIH study, funded study right now looking at short-term outcomes after treatment of Lyme meningitis in children. It's the PI is Lisa Negrovic at Boston Children's. It's not per se a long-term outcome study focusing on post-treatment Lyme disease, but it is looking at outcomes of antibiotic therapy of Lyme meningitis and comparing IV ceftriaxone and oral doxycycline. That's the closest thing to a study right now, but there have not been any good studies in children. When you ask peds ID people, they have a gut feeling that it's less common, and that wouldn't surprise me because, you know, children don't have the comorbidities and, you know, other issues that adults have. But that's yet to be proven.
Okay, thank you very much.
Thank you, Natasha. The next question is from the chat box. Are there any predictors of chronic Lyme stemming from the pattern or severity of the initial Lyme presentation?
Yeah, so risk factors for PTLD include more severe initial presentation, TLR2, there's a TLR2 SNP that's associated with outcomes. And then we've shown in our research that prolonged elevations in CCL19, which is a T cell chemokine, is associated with the eventual development of post-treatment Lyme disease syndrome. So there are some early data on prolonged inflammation. There's also gene regulation signatures that Charles Chu at UCSF has published, and a group at Mount Sinai that we work with that suggests that gene regulation patterns are altered and that those may be distinctive enough to serve as a diagnostic tool in the future. You know, that the gene responses are different for Borrelia infection, and that the upregulated genes remain upregulated over time in the people that develop post-treatment Lyme disease. So there is an emerging, you know, science on biomarkers that could be predictive for PTLD. Again, CCL19 is the one that we've published on.
Thank you. Our next question is, hi, Dr. Aucott. How often do specialists from, say, Johns Hopkins LDCT collaborate with infectious disease specialists or associations or specialized Lyme labs in Canada, like the Diagnostic Foundation at University of Guelph, with these latest results? It seems that Canada's approach to testing, diagnosing, and treating, especially chronic of PT Lyme disease.
So I think the question was about collaboration. Is that
correct? About collaborations with, for example, the University of Guelph, the Diagnostic Foundation, and others that are looking at infectious disease specialists.
Yeah, so you know, we're probably the most collaborative group in the world. So I didn't put up the slide, but you know, I think right now, I'm not exaggerating, we have about 25 active collaborations going on. So we're really not we're a big collaborator. So we collaborate, you know, all across the United States. We're open to collaborations in Canada too. It's not, you know, we really literally collaborate with anybody who's a good scientist that has good research questions. And, you know, the foundations are often funders of that. I mean, the big funder in the United States is the Stephen and Alexandra Cohen Foundation, which has been a huge funder for research in the United States. And so we're super open, obviously, to working with patient foundations, family foundations that are interested in stimulating collaboration. Yeah, so collaboration is key to moving the field forward. And we're totally we do, honestly, we do more science with institutions outside of Hopkins than we do with Hopkins, just because we go where the opportunities are, and the funders often help determine some of the opportunities.
Thank you. We'll have last two questions. One's from the chat box and then one's from the audience, and then we'll wrap it up as we're just at the 1 hour mark. And I know everybody has a lot of things on their schedule. This question from the chat box is, are there any associations between environmental or social economical factors and PTLD?
So, one of the key things that we're going to start looking into is there's a lot of indirect evidence that African Americans and people with dark skin may be at higher risk for late manifestations and then late diagnosis and treatment as a risk factor for PTLD because of the difficulty seeing rashes in dark skinned people. And so it's a huge area of interest that we need to do more research on. So I would say absolutely yes. Also want to circle back, I forgot to mention about collaborations. I really forgot to say, Adrian Browncheck and I are working on a cross-border collaboration on Lyme carditis and longer-term outcomes of Lyme carditis. So that's an example of we're actively putting together a collaboration between Adrian and the cardiologists in our group at Hopkins. So that's an example of a cross-border collaboration that we're forming right now. So just another example of that.
Thank you. And our last question is from Dr. Vardo from out west. Go ahead, Dr. Vardo, please unmic and ask your question.
Great. Thank you very much, Dr. Aucott, for your really interesting presentation. You had said earlier on that there's some pathogens that seem to cause these chronic syndromes, and SARS-CoV-2 was one, and Borrelia burgdorferi is one, and then others like the influenza virus is not. And these pathogens are all very different. And I was wondering, are you developing any sort of intuitive sense as to why some of these pathogens cause these chronic problems, whereas other ones are less likely to? Any thoughts about that?
I mean, it's total speculation, but group A strep, was the classic, thing that's taught to every medical student and fellow. Group A strep, it's thought to be because of molecular mimicry, right, where the antigens in group A strep mimic the cardiac antigens in the human heart. And so that's always taught as the example of molecular mimicry. So I think, some of organisms, just because of bad luck, are going to have antigens that mimic human antigens, and that mechanism of molecular mimicry is going to pertain. But I think a lot of the other ones, like Epstein-Barr virus and Q fever, a lot of those you wonder whether it has to do more with the organisms being more, capable of causing prolonged infection, right? So Q fever and SARS-CoV-1, though that's not quite the same. But, I have this gut feeling the ones that cause prolonged infection may be at higher risk. The story about Borrelia burgdorferi, of course, is really interesting because it's a zoonosis. So it's a professional chronic infection, right? It has to live in its reservoir host, which is a mouse. So it's the classic prolonged infection in a mammalian host. So, I think some of them, it's because they cause by their very nature prolonged infection.
Right. Okay. Thank you very much.
Yeah.
Thank you. I'm just going to quickly switch over. I do want to thank Dr. Aucott for his engaging presentation and for taking the extra time to answer everybody's questions, and for everybody for staying on the call. I just wanted to remind you that we still have one more presentation this week. Actually, Dr. Vardo's PhD student, Alexandra Foley-Eby, will be presenting tomorrow, Friday, May 6th at noon on evaluable inheritance. Co-infection with multiple strains in the mother reduces the protective efficacy of the maternal antibody response in the offspring. We hope you can join us tomorrow at noon. And just a reminder, if you have time, take part in our challenge, wear green or wear green face masks, take a photo and share it with us to help spread awareness for Lyme disease. If you don't like to send in personal photos, you can just send in any artwork that you do that represents Lyme Disease Awareness Month. Any entries that are submitted by the deadline of May 31st will be entered into our draw of one of four $25 Starbucks e-gift cards, and they can be sent to clydern@gmail.com. Again, thank you, Dr. Aucott, for taking time today to present to our group. And wish everybody a good rest of today and the rest of your week. And I will stop the recording.